Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. So today we're going to be talking about a basic approach to the shoulder radiograph. As with basically all studies, you're going to take a look at the indication, patient history, underlying conditions, things like that, look at prior studies, and then we'll look at the study to see what sort of views were provided and any limitations to those views. And typically what I like to start looking for is basically fractures and osseous lesions first, look for malalignment or dislocation and sort of ligamentous abnormalities next, and then I'll take a look for abnormal calcifications, look for abnormalities in soft tissues, and then it's really important to make sure that we don't miss anything in the incidentally imaged chest or other anatomy outside of the upper extremity. Okay, so let's get started. So here we've got our shoulder radiograph, and let's presume that we've already taken a look at the patient history and understand what's going on. You'll see that we have three views, like an AP and an attempted Grashy, but we don't actually kind of see down the joint space here, so this is a little bit limited. And we have an axillary Y view. We don't have like the kind of like acromial view, or I'm sorry, the axillary view. We don't, there's all sorts of special views to look for Hill-Sachs lesions, for Bankart lesions, and in the case where the patient can't abduct the arm, where there's different maneuvers, but we have here just kind of like something pretty standard. So typically what I'll do is just, it's important to kind of window closely and look very carefully at each of the cortices. You have to remember, this is kind of big picture for all skeletal x-rays or for any sort of radiographs of osseous structures, is that fractures don't just appear as abnormal lucency or cortical abnormality. You can actually see, you have to look at the medullary space. You have to look for, abnormal, calcifications, periosseal reaction, just, all around, surrounding the bone, at the cortex, at the where the medullary cavity projects. So I'm going to look at basically every single osseous structure here. It's important not to forget to look at the entire scapula, coracoid process, acromial process, clavicle, and then also take a look at the visualized thoracic cage. You're going to see part of the neck and kind of facial structure sometimes as well. We're going to do that on every single view, basically, looking carefully for fractures, for osseous lesions, sclerotic, lucent, mixed, etc. Do that in every single view and be particularly careful that differing parts of the anatomy can be visualized in each view. Okay. It's important also to get a sense as to what the relative position of the humeral head to the glenoid. On a true Grashy view, you should see the joint space here, and you can kind of get a sense of the relative position in the anterior-posterior direction on the scapular Y view. Okay, you just want to make sure that the humeral head is well centered on the articular surface of the glenoid right there. All right. What's really important, and I want to just emphasize this again, is to just make sure that using these other views, you look at every single aspect of the osseous structures, particularly the coracoid process, the acromial process, the acromioclavicular articulation. All right, and the whole scapula. The whole, can be very easy to miss on these other views. Any sort of abnormalities there, which can be very subtle. Kind of another thing you want to make sure we're looking at are the acromioclavicular distance, the coracoclavicular distance, okay, and then the acromohumeral difference, or distance. See if higher in humeral head, can look for kind of ligamentous abnormalities in these areas. If you have an axillary view, you can kind of, that can be particularly helpful in addition to the scapular Y for look for anterior-posterior dislocation. We're gonna, in addition to kind of looking for osseous lesions, for dislocation, ligamentous abnormality, you're going to look for abnormal degenerative changes, the usual osteophytosis, sclerotic change, cystic changes, at the joint space, the acromioclavicular, the glenohumeral, and then, and if we've already kind of taken a look at the osseous structures, just to be cognizant that not all osseous structures are fractures or obvious destructive lesions. So we need to look just very closely at everything there. Next, we're going to make sure that particularly if there's no abnormal calcification in the soft tissues and no abnormal lucency, as you might, as can be seen in certain circumstances, such as like calcific tendinitis or if there's subacute air. And then lastly, what I like to look at is just make sure that I'm very careful to look at the visualized lung and mediastinum and basically the whole incidentally image thoracic viscera here, just to make sure we're not missing a nodule, a mediastinal, like an obvious mediastinal mass, apical capping, any sort of pleural abnormality. You can recognize we also see part of the airway and the neck, the lower face here. And it's just to make sure that we're not kind of missing anything incidental. In addition to looking at like what we're imaging frequently, just if we're just focusing on the osseous structures of the shoulder. So as a recap, with a shoulder radiograph, you're gonna get a sense as to what's going on with the patient, and then be careful to look at the bones, look for dislocation, ligamentous abnormalities. We're going to look for in the soft tissues for abnormal lucency or calcification, and then make sure that we don't forget to look at the incidentally imaged chest for any sort of incidental abnormalities.